So good morning again and welcome to my talk on tyrosine kinase inhibitors and cardiovascular disease. In my talk, I will use CML, chronic myeloid leukemia, as a model, and I will refer to the various TKIs used in CML and will try to focus on the true and evidence-based cardiovascular adverse events of the different TKIs. For those in the audience who are not familiar with CML, who are not hematologists, I would like to give a brief update on CML and TKIs. CML, or chronic myeloid leukemia, is characterized by uncontrolled expansion of myeloid cells caused by overexpression of the BCR-ABL1 oncogene. Since 2001, the BCR-ABL1 tyrosine kinase inhibitor imatinib is considered the gold standard of treatment for CML patients. However, resistance or intolerance to imatinib may occur, necessitating the use of second and third generation TKIs. These include nilotinib, dasatinib, bosutinib, and ponatinib. With the success of the second and third generation TKIs in second-line treatment, they were applied also for first-line treatment with excellent results. In recent years, cardiovascular adverse events emerge as a clinically relevant problem in patients receiving tyrosine kinase inhibitors. In this table, you can see the profile of non-hematological adverse events of CML patients treated with TKIs. This lecture is devoted to those events related to cardiovascular issues. These are marked with a blue line in the table, and the relevant frequencies are presented according to the different tyrosine kinase inhibitors. You can see, for example, that pleural and pericardial effusions are unique for dasatinib, while nilotinib and ponatinib are notorious for arterial occlusive disease. This cartoon gives an idea about toxicities common to all TKIs and those unique for specific ones. In the center, you can see the common ones, like myelosuppression and liver and enzyme and electrolyte disturbances. You can also see surrounding the circle some of the unique side effects for each agent, with imatinib on top causing edema, fluid retention, and myalgias, nilotinib on the left side causing pancreatic enzyme elevation and indirect hyperbilirubinemia, as well as QT prolongation and peripheral arterial occlusive disease, dasatinib with a notable amount of pleural and pericardial infusions, and bosutinib, which is infamous mainly for its gastrointestinal side effects. Last but not least, ponatinib on the upper left side is mostly ill-reputed for pancreatic abnormalities as well as venous and arterial vascular events. This slide summarizes the main issues related to the cardiovascular toxicity of the TKIs used for CML, which will be discussed in the next 15 minutes. Imatinib is associated with congestive heart failure, although this is still controversial, as you will see later. Pleural and pericardial effusions are associated with dasatinib and bosutinib, and pulmonary hypertension was reported in several patients treated with dasatinib. Peripheral arterial occlusive disease is more and more described as an adverse event of nilotinib, while ponatinib is associated with both arterial and venous thrombosis. All TKIs, but mainly nilotinib, can induce QT prolongation. This side effect will not be discussed today. I would like to start with the controversial issue of congestive heart failure and its relation to treatment with imatinib in CML. In 2007, Kerkela et al. Published 10 patients who presented with severe congestive heart failure while treated with imatinib 7 months after the initiation of treatment. These patients underwent myocardial biopsies which showed toxin-induced myopathy. This was probably caused by an insult to the mitochondria caused by imatinib, which triggered energy rundown. In the same year, the group from MD Anderson published a contradicting article reporting on a very low rate of congestive heart failure among patients treated with imatinib and summarized that imatinib is uncommon as a cause for congestive heart failure. In their cohort of 1,200 patients, CHF could be attributed to imatinib in 8 patients only. These were mainly elderly patients with cardiac risk factors. They concluded that patients with previous cardiac history should be monitored and treated aggressively if they develop symptoms suggestive of congestive heart failure. Another article which examined this issue prospectively was published in 2011 by an English group. In this study, 59 CML patients treated with imatinib for a median of 3.4 years were evaluated by using echocardiography and repeated Muga scanning. There was no evidence of CHF, and the authors summarized that imatinib cardiotoxicity should not be of clinical consideration. Other large clinical cohorts, including the IRIS trial, which is the largest and most established trial for imatinib first-line in CML, could not support an imatinib-related cardiotoxicity, and the reported rate of this adverse event in these trials was less than 1%. The next part of my talk will be dedicated to pleural effusions associated with dasatinib. Dasatinib mainly, but to a lesser extent also bosutinib, has been associated with pleural and pericardial effusions. The prevalence is highly variable but fairly significant, ranging between 14 and 60% of patients taking dasatinib. Several risk factors have been implicated. The most established ones are dasatinib dosage above 100 milligrams daily and dasatinib schedule, namely divided doses as opposed to once daily intake, and the presence of large granular lymphocytosis. This issue and its relationship to pleural effusion will be discussed in detail later. Interestingly, CML patients treated with dasatinib who develop pleural effusion tend to have better molecular and cytogenetic responses as shown in this slide. Here you can see the data of a Turkish group showing that in patients treated with dasatinib, there was a significant difference in the rate of molecular as well as cytogenetic response between patients developing pleural effusion and those who did not, in favor of those with a pleural effusion. In the coming slides, I would like to discuss a very interesting association between treatment with dasatinib, the presence of large granular lymphocytosis, the occurrence of pleural effusion, and good response to treatment. Large granular lymphocytes are a subclass of white blood cells with a characteristic immunophenotype. They can be found in patients with autoimmune disorders, amongst others. Several studies showed a correlation between the occurrence of pleural effusion and the presence of large granular lymphocytes in peripheral blood of patients treated with dasatinib. Actually, the presence of LGLs, large granular lymphocytes, preceded the development of pleural effusion in these patients. In line with these findings, pleural effusion developing in patients treated with dasatinib is an exudat and usually contains LGLs. The presence of LGL cells in the blood of patients treated with dasatinib and the occurrence of pleural effusion is associated with better response to treatment. A postulated explanation is that dasatinib, through its feature as Src tyrosine kinase inhibitor, induces immune reactivity, which is manifested by the presence of LGLs. This, in turn, is associated with better responses of the disease on the one hand, and with autoimmune-like adverse reactions such as pleural effusion on the other hand. This table summarizes the studies evaluating the relationship between the development of LGLs, pleural effusion, and response to treatment. You can see that the presence of LGLs was associated with higher cytogenetic and molecular responses to dasatinib on the one hand, and with a higher prevalence of pleural effusion on the other hand. Here, I tried to depict the interrelationship between dasatinib, large granular lymphocytes, pleural effusion, and response. Dasatinib, through its inhibitory effect on star kinase, influences the immune system. This in turn causes an increase in the number of LGLs, which are mediators of immune response. CML is a disease which responds to immune manipulations, like those induced by interferon or by graft versus leukemia effect. Thus, the immune changes caused by dasatinib and mediated through the rise in LGLs have a favorable effect on the response to treatment on the one hand, and are responsible for the occurrence of exudative pleural effusion on the other hand. The net result is the presence of LGLs, the occurrence of pleural effusion, and better response to treatment. I will devote the rest of my talk to peripheral arterial occlusive disease, which is mainly an adverse effect of nilotinib and ponatinib. Several types of vascular adverse events were described in patients receiving second and third generation TKIs. These include pulmonary hypertension in patients receiving dasatinib, peripheral arterial occlusive disease in patients receiving nilotinib, and venous and arterial vascular occlusive events in patients receiving ponatinib. Awareness to vascular adverse events in CML patients treated with TKIs increased only in recent years. Several causes might contribute to ignorance of these side effects. These include the low number of patients per center participating in clinical trials, since CML is rather rare disease, the fact that atherosclerotic disease is rather common, and the fact that most clinical trials excluded patients prone to develop cardiovascular side effects. Furthermore, vascular adverse events are not related to as an oncological side effect, and thus might be underreported. And last but not least, these adverse effects are underreported since the latency period between the initiation of treatment and the development of vascular events is relatively long. The first vascular side effect to be discussed is pulmonary arterial hypertension associated with a limited number of patients on dasatinib. This is a very rare adverse event comprising less than 1% of patients. This adverse event, unlike pleural effusion, which is also associated with dasatinib, is not fully reversible and might have severe consequences. Due to the small number of cases, no risk factors have been identified so far. During the last years, more and more cases of peripheral arterial occlusive disease related to nilotinib have been reported. All arterial bed might be affected, including peripheral vascular disease, coronary arteries, and cerebral arteries. The exact incidence of symptomatic artery disease is unknown, with a wide range in published studies. There is a strong association with the presence of risk factor for cardiovascular disease or with previous cardiovascular disease. Although several mechanisms have been suggested, including endothelial insult, platelet dysfunction, and others, the exact mechanism is still unknown. Results from large studies like the ENESTEN trial, which compared imatinib to nilotinib in first-line treatment for CML, showed a significantly higher rate of cardiovascular events with nilotinib compared to imatinib. These were dose-dependent. Importantly, 85% of patients with a cardiovascular event had at least one risk factor and were not optimally managed for hyperglycemia and hypercholesterolemia. The largest trial evaluating the occurrence of peripheral arterial occlusive disease in CML patients treated with nilotinib compared to imatinib included 159 patients evaluated for clinical and biochemical risk factor for cardiovascular disease. You can see on the slide the different subgroups according to treatment. Here you can see the results of this large trial. ABI, namely ankle brachial index, which is a surrogate for clinically relevant atherosclerosis, was chosen to evaluate the degree of peripheral arterial occlusive disease. Nilotinib was clearly associated with a higher rate of peripheral arterial occlusive disease, as represented by a higher rate of pathological ABI and by the higher rate of pathological duplex sonography or severe vascular adverse events. In search for the contributing factors to the development of peripheral arterial occlusive disease in CML patients treated with nilotinib, the French group evaluated cholesterol levels in 27 patients treated with nilotinib. They showed that the proportion of patients with non-optimal LDL cholesterol levels increased from 48% to 98% by 12 months, leading to a cholesterol-lowering drug intervention in 22% of patients. Their conclusions were that it is mandatory to follow lipid profile at baseline and during follow-up in patients treated with nilotinib. Although no evidence-based firm conclusions regarding the pathogenesis of nilotinib-associated vasculopathy have been established so far, several mechanisms have been postulated. These include metabolic effects like insulin-resistant and hypercholesterolemia, direct pro-atherogenic effects, and stenosis-augmenting effects like those affecting the endothelial cells, anti-angiogenic effects on endothelial cells, and abnormal platelet function effects. Further studies are needed and are underway to evaluate these potentially contributing factors. And last but not least, ponatinib, a TKI used to treat patients with drug-resistant CML, has been associated with both arterial and venous thromboembolic events. This led to its temporary withdrawal from the American market by the FDA in the end of 2013. However, the drug was reintroduced after several amendments, including dose reduction and better surveillance. In this slide, you can see a summary of the leading studies reporting on the occurrence of vascular occlusive events and peripheral arterial occlusive disease, mainly during treatment with nilotinib. You can see that the follow-up period was long and that the range of prevalence of these adverse events among different studies was quite wide. What measures should we take to reduce the risk of vascular adverse events in patients with CML treated with TKIs? This can be handled in a stepwise approach. First, a thoughtful patient selection for treatment with nilotinib and ponatinib, namely choosing patients with low peripheral arterial occlusive disease risk score. Then, adding relevant medications like aspirin, statins, etc. to the treatment according to the guidelines. And last, event management and modification of therapy once vascular events have occurred. So to conclude, imatinib is considered rather safe in terms of cardiovascular toxicity, while the second and third generation TKIs are less safe. The pathogenesis of vascular adverse events induced by these TKIs is still unknown, but it seems that direct pro-atherogenic and growth inhibitory effects on endothelial cells, as well as metabolic drug effects, contribute to the pathogenesis. Thus, it is of great importance to consider the overall risk profile of a patient before starting therapy, to include comorbidities and risk factors for peripheral arterial occlusive disease development in novel treatment algorithms, to monitor metabolic and cardiovascular parameters in patients treated with these drugs, and to reduce the vascular risk by optimal patient selection, co-medication, and early intervention. So here I conclude, and I would like to thank you for your attention, and I'll be happy to take one or two questions if you have.